All right, well, welcome everyone. We'll go ahead and get started. I expect a few people will kind of filter in as we get going. So I'm Jeff Staub. I am the outgoing chair, a few more days as chair of the ACLP Research Subcommittee, and here with Maria Prom, who's my vice chair, and will be the incoming chair of the committee. I just want to let you know that thank you all for coming, both the people who have joined us as mentors and all of the rest of you as mentees. This has been more than a year in planning and really is the culmination of lots of discussions that we've had in the subcommittee about the best way to bring together senior people who are in the academy, also ones who are guests from outside the academy, and people who are on the track of developing their research. And it's not been entirely clear how best to do that. So we're going to give it a go this way this year. And hopefully by the end of the day, you'll be able to tell us what we did well and what we didn't do well. And please don't be bashful about letting us know both of those things. I'm going to turn things over to Dr. Prom. This is, we had a committee of 5 people, and I'll let Dr. Prom introduce the others. But I have to say that this wouldn't have happened without Maria's hard work. So thank you very much, Maria. So I'll let her kind of take us through the logistics of the day. And hopefully each of you, no matter which of the tracks that you're on as the afternoon progresses, will find something worthwhile to take home and launch you another step or two ahead in your research trajectory. So with that, thank you all for being here. Maria, please come on up.
Thank you very much, Jeff. And thank you to all of our mentors, our speakers, our participants. I'm going to go through some logistics, some housekeeping before we get started, and then we'll get moving. We've created a jam-packed afternoon, so hopefully we can keep on time. I want to start by just a couple quick housekeeping things. Mentors and speakers, if you haven't already, there's some packets in the back to help you guide through the day. If you were a participant, if you can check your name off, we just want to keep track of everyone who came and who had registered. You can do that during the break. At some point, there's a couple sign-in sheets. They're the same. Just check your name as you go. And additionally, everyone should have received a schedule by email. We just saved some trees. We didn't print out schedules for everyone. We do have a few copies if for any reason you can't access it on your phone. I'll set some of those back there. The agenda for today, there we go. We'll start, it's a little small, but 12 to 12:05, we're going to have our welcome remarks as we are doing now. We'll have our first keynote, Dr. Michael Fried, and then we'll have Dr. Priya Gopalan after that. Then we'll have a short break. And after the break, just remember to go directly to your individual rooms, which are listed up here for your sessions. We'll have another break, and then people will return to the rooms again for further breakout sessions. No, first technical difficulty. Well, the other slide I wanted to present while we're fixing this, I just wanted to thank our working group who has been working tirelessly over the past year to put everything together. Mark Bradley and Zev Nakamura. Where did Zev go? There he is, hiding in the back. And then Katie Sheehan, who can't be here today, but had put in a lot of work ahead of time.
Why are you doing this?
We're going to begin today. We'll have two keynote speakers, as we mentioned. Our first keynote, we're really excited to have Dr. Michael Freed join us today. He is the Chief of the Services Research and Clinical Epidemiology Branch at the National Institute of Mental Health. Under his guidance, the branch sets research priorities, develops funding initiatives, and administers a public health-oriented research portfolio to increase access, continuity, quality, equity, and value of mental health services in those in need. The branch also leads their NIMH's dissemination and implementation science research agenda. In his role, he leads and co-leads various initiatives across NIH and across the federal government. Thank you, Mike.
Great. Thank you so much for having me. And really thank you to Maria and Jeff and Mark, here you are, as well as Sejal Shah and James Rack and Marilyn Powell for really kind of starting this and getting this all together. So it's a real honor to be here, and thank you again. Great. So NIMH really isn't where I thought I'd end up. Clinical work was my calling, and or really so I thought, because I'm standing here today representing a funding agency. Prior to grad school, I worked as a counselor for troubled teens. The program was co-founded by Ted and Susan Wachtel, people you may not have heard of, but were very influential during the formative parts of my career. Ted had co-authored the book Tough Love, and the program that he and Susan developed really centered around peers influencing peers, personal empowerment, natural consequences, the importance of community, and the idea that just because somebody was dealt a bad hand in life doesn't mean they can't make good decisions to turn their life around. This worldview was complemented by that of Viktor Frankl. I read his book, and he's a famous psychiatrist who was imprisoned in a concentration camp during Nazi Germany, and came to write that one always has a choice. And then these beliefs were also congruent with an organization in Rockville, Maryland called Housing Unlimited, Inc., that provides housing to people with mental illness. So when exploring thesis ideas, evaluating a housing agency really wasn't all that appealing until I learned more about the model. It really was innovative at the time because housing eligibility was severed from any requirements to seek or be receiving treatment. Tenants, as they were called, there were natural consequences for not taking care of oneself, but treatment really wasn't required. And this was not the continuum of care model that most of us are familiar with. It's an intriguing model, and one that I really found intriguing because I was training to be a clinician and be delivering treatment, and this was not associated with that. And in fact, even during the evaluation, I had to really negotiate with folks to be able to assess symptom level functioning, because they really didn't want treatment or anything connected with treatment to be associated with the evaluation. While on internship at the VA Pittsburgh healthcare system, I had 3 rotations. The first was in the Center for the Treatment of Addictive Disorders, which made the most sense given what I wanted to do with my career. I was forced to rotate through their primary care rotation. And I knew a little bit about integrated care. It wasn't a passion of mine. And I, really wasn't interested in doing any type of bedside treatment. And then the third rotation was in the PTSD clinic. And it started off like learning about PTSD, and then it really blew my mind about what was involved. The wars in Iraq and Afghanistan were just ramping up. And as you know, VA serves not just veterans of the current war, but at the time, they were treating veterans of World War II, Korea, and Vietnam. And the relationship between veterans and the VA was somewhat odd when it came to benefit seeking. Certainly, if you come and you want treatment, no problem. But benefit seeking got a funny look, right? And there's real concern about veterans coming in, exacerbating their symptoms, wanting to get money. And there was a machine in place, right? So veterans were being coached by service organizations. So they were coming in knowing what to say, and the VA was saying, hey, wait a minute, we're being coached. And there's this kind of strange relationship. And PTSD really was a coveted diagnosis to have, because it meant something happened to you while you're in the military, and it was okay. There was no stigma. You're saying, hey, this bad thing happened to me, and now I want benefits for it. And so here I really observed that, systems and policies can really make a difference in how clinicians behave and how patients behave. So my first job as a minted PhD was in the Deployment Health Clinical Center at Walter Reed Army Medical Center. I heard about the position from a fellow alum, and it was the title was a clinical research psychologist. So it seemed interesting. Had all the benefits of a postdoc except a real salary, and there was no fixed end date to my tenure there. So it was good in that respect. And whereas at the VA, there was a concern about malingering, here at Walter Reed and across the military health system, it was actually the opposite. So when you think about stigma, one might say, well, it's kind of a perception of being slighted, right, for having a mental health condition. Oh, no, there were very real repercussions to saying, hey, I have this diagnosis and I want help for it. It could affect career promotion. It could affect your ability to stay in the service. And even, you can go back one slide. So even here, the Army was pilot testing a program. So to encourage self-referral for service members that had alcohol problems, because in the Army, alcohol was not just a psychiatric condition, it was actually a personnel issue. So very different from how we think about things. The purpose of the military health system is really to ensure that we have a fighting force. So when we think about healthcare today as tied to workforce in the military, it's really tied to workforce. So my supervisor and mentor at the time, Dr. Charles Engel, was one of the few health services researchers in the military, and he had his hands in a lot. And kind of like, and when I say a lot, the purpose of research in the military, at least that I was exposed to, was really to help solve very operational questions and do so quickly, right? So this includes helping to identify service members with PTSD, thinking about non-stigmatizing ways to get them treated. So, conducted a trial of acupuncture for PTSD, learning about risk of who's most at risk of coming in with problems, studying a medication called prazosin, which is cheap, right? And there was some really promising research, and this was to help with sleep disturbance. So it might, raising your hand and saying, hey, I have PTSD is very different than saying I have sleep disturbance. So testing this medication was important. And also thinking about very brief ways to identify patients. So, we developed a one-question screener for PTSD. And you may think, well, why one question? It's like, well, if you remember that movie, Something About Mary from, maybe 20 years ago, what's better than 8-minute abs, 7-minute abs? Well, here in primary care, right? What's better than a 4-question screener or 1-question screener? And so it's here that things really begin to click, that despite personal choice, right, feeling empowered, and all those things that I thought really were driving behavior, the system can do a lot of stuff to make things easier or harder for people to get care. So as I thought about health services research, I needed a rubric, and this is one that's very simple, and I like because I still use it today. And it's really from, the idea of going from point A to point B, right? And you can see the point A is like, there's a problem identified for those in need. And point B is effective treatment is available and efficiently delivered with fidelity. We can develop a lot of components of good care, but it's really important to have a system of care and put those components in place in a way that's coherent and makes a lot of sense. So again, using this rubric, there were some researchers, Charles Hogue and colleagues and others in the early 2000s that began to look at some epidemiological data. And so what I'm going to show you here is just sort of a kind of cocktail napkin way of explaining how I think about population health. And when you think about of the 20% of soldiers with moderate to severe disorder after OIF, as Operation Iraqi Freedom Deployment, right? We knew that most acknowledged that they had a problem. Still, most wanted help for that problem. About half received any help. About half received help from a mental health provider, and far fewer received what we would consider minimally adequate care. So as we go to point A to point B, we see that the denominator stays the same, but the numerator shrinks. And at the time, many of my colleagues, and really me included, I would say were somewhat myopic in what the solutions were, because it focused only on the smallest bubble. And we would develop these interventions and try to test these interventions without realizing that we had this whole denominator of target populations that weren't coming in. So the solution of just focusing on the intervention at the point of care was not broad enough. And so let me kind of hammer this point home. One of my informal mentors, Dr. Doug Zatzik, writes about a concept called population impact. And so this really struck a chord. And just humor me for a second, especially after, on the heels of Halloween. So if you look at the top left, that's a graphic of Nosferatu, who's a cheap Dracula knockoff. And I'm from the government, and rather than pay for or use your taxpayer dollars to pay for clip art, went with the free one. Okay. And so if all you had to worry about was Nosferatu, you can invest a lot of time in getting the best wooden stake money could buy and sharpen it just right so you can kill or re-kill the undead, by driving that stake through its heart. However, most of us, I would say, are probably in a zombie movie, right? Where you have fast and slow moving zombies, and the one that's either chasing you at the door, right? You know that there are more. You don't know where necessarily, but you just know that there are more. And the one, if you focus your attention only on one, you're missing others. So as you think about population impact, it's really about both the effect of the intervention on any one person multiplied by the number of people in need, right? And here the point really is to remember the denominator always, right? And as a clinician, you are seeing one piece of the numerator, the patient in front of you. And when you look at research studies, right, you're seeing a sample, and oftentimes this is a selected sample, right? Meaning that in part of research, you have a research assistant that can wrangle patients to participate in your study. And you want to be thinking, is this really my target population? And what am I doing, for the target population? So then how does one design a system of care for population impact, right? In the military, you might think, things are on the left, make it happen. And this is a framework, from Greenhall et al. Published in 2004. And the idea of innovations that you have a more passive way, kind of let it happen. You can maybe nudge it, help it happen, or kind of make it happen. And make it happen, really takes a lot of work. And so when you think about this, even with all these ingredients in place, can you build a system of care that people will adopt and use? Maybe. So who's familiar with the collaborative care model? Great. The Army was an early adopter. Collaborative care is a system of care that puts in place, what we think are effective components of good care integration, right? You have a prepared primary care practice with routine screening for indicated conditions, referrals, real-time use of a disease registry to make sure that, we're paying attention to all patients on a panel and not just those at the primary care's office. You have dedicated care management, a psychiatric consultant, and it's, we know that there's a lot of evidence for common mental health conditions. And so let's use this point A to point B model again, right? So the Army's collaborative care program was called Respect Mill. And we knew that, and this was rolled out in approximately 93 clinics across the world. And we knew that of the 3.9 primary care visits, we could see that 3.4 million of those, we saw screens, right? So that's 88% for PTSD and depression. Of those, 450,000 were positive, 211,000 had a presumptive diagnosis. We identified 123,000 unmet mental health need, and about 25,000 were followed in Respect Mill. We then submitted a grant application to the DoD to test enhancements. My boss and mentor, Chuck Engel, he was the initiating PI. I was a co-investigator, and a really stellar team that included Wayne Caton, Jürgen Nitzer, Doug Zatzik, Lisa Jaycox, and Terry Tunelian. And we applied for this funding and received funding to conduct. I received $15 million to conduct a multi-site randomized effectiveness trial. It was conducted at 6 military treatment facilities across the United States, about 18 clinics altogether. And this was to test enhancements to the existing military's program. And those enhancements included, better training for care managers to deliver behavioral activation, motivational interviewing. We had centralization of a lot of services, knowing that like care managers, change jobs and move, and you don't want to leave a site without a care manager. We added, at the time, really innovative web-based therapies for PTSD and depression, telephone therapy. And even this sort of enhanced follow-up. And when I say, we knew that transitions from DoD to VA were challenging, we were able to push the boundaries a little bit because this was research. And what we would get, or folks, arguably regulators saying, well, hey, you're providing these services. Well, what if a service member is transitioning out of the military and that service member, is at risk for suicide, and you're still following them? We can't control them. And the response was, yeah, what if, right? They have nowhere to go. They haven't made a connection yet to VA. And so this is a service that we think is important to do. And we see that, in terms of what we found, we saw improvements in PTSD and depression symptoms. These were not overwhelming findings, but they were, positive nonetheless, and seemed to get better with time. Some preliminary findings about reductions in suicidality. It improved organization of care, meaning that, and quality of care, meaning that, service members with more acute needs were more readily referred to specialists. And so this allowed for, primary care to address needs of patients that were less acute. It addressed high priority topics and concerns from a variety of stakeholders. Our cost effectiveness analysis determined that it was of high value. It actually improved reach and effectiveness. We did some modeling, and so it improved population impact should this have been implemented. And it leveraged the existing collaborative care infrastructure, so it had a lot of real world generalizability to it. And eventually, the trial was mentioned in the VA-DoD clinical practice guidelines. So, with overwhelming evidence that we thought was practice relevant, did this enhancement to respect mail get implemented? No, it did not. And actually, over time, the military's collaborative care program was slowly dismantled in favor of another model of care integration. So my job evolved, and the little engine that could, Deployment Health Clinical Center, got kind of scooped up by a larger organization called the Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury, along with a couple other centers that kind of focused on different things. And as they were standing up and trying to find their mission, they were kind of ambivalent about research. And I really wanted to be a researcher at this point. I was really excited about the data and was really reluctant to do other things because I just kept getting asked to do kind of more administrative things, or at least so I thought. And DECO, as they were known, positioned themselves to kind of be the bookends of research. So on one end, you have priority setting on the left. On the other hand, you have knowledge translation on the right. So they were like, not sure if we want to actually do research. So on the priority setting side, I began to understand what folks in the DoD program office did. So kind of what I do now, but at the time as a researcher, kind of being annoyed by saying, well, where's this thing? Where's this thing? What are the updates? And it was helpful to be in a position where I wasn't just generating data about one particular project. I began to think about, but I was able to use data and be able to think about how the research enterprise and the research to practice enterprise could be better. So for example, out of our trial, we took advantage of it was a natural experiment where at the time you couldn't pay service members to participate in research. You could pay them for blood draws, but not for research participation. And that changed. And so we're able to, study the impact of that. And we're able to write about some of the really profound regulatory hurdles of trying to get research done in an organization where research has such a practical implication. And if you're so focused on, if you're so focused on risk and not attending to also that risk-benefit balance, you may be holding things up for an organization that really relies on those findings. And so that was pretty exciting. And then, on the bookend side, remember that prazosin trial I was talking to you about? Well, at the time, there was really renewed interest. The DoD had spent, over $1 billion on research for PTSD and TBI, and they needed something to show for all those expenses. And so the organization tapped to help with knowledge translation. Thought, well, what about prazosin? It was off patent. The efficacy evidence was really, really promising to reduce traumatic-related nightmares. The lead researcher, Murray Raskin from VA Puget Sound, super smart, super charming. And there was even a paper written at one point about prazosin prescribing in relation to his geographic location. Those findings had over time kind of diminished, but it was, again, a really exciting time to think about, well, why not? Except when you looked a little closer. When you peeked under the hood of the trials, right, you saw, well, are these really active duty service members that were in Iraq and Afghanistan? When you think about some of the major side effects of the medication, is this what we want for our service members in a desert situation where the primary side effect is hypotension? And then having kind of an inside scoop that there's going to be findings from a major trial, the most robust trial to date, coming out on prazosin, showing that it really didn't work as well as we thought. So it was a disappointing story in some ways, but it was really important for me to be in this position because of the folks that were involved. I had by far the most experience with the medication, and it was able to kind of see the science. And so my experience at the DoD really, I think, prepared me kind of reluctantly to be a bureaucrat at NIMH. And so when a position opened up, I embraced my inner bureaucrat and applied. And leaving the DoD was bittersweet because I'd spent 10 years there, but I was really excited to step into my next career. So one of the most exciting parts about working for the funding agency is directing where research dollars go. And it's not about one project, but it's about a program of research and really seizing on opportunities when they arise. So the cascade of care for unmet mental health need, that pattern, presented itself again, with the opioid epidemic. So on the left, what you see is kind of, we think about maybe for depression, but on the right, this is a paper published using data, a little bit antiquated data, but basically, what we saw was this huge need. And then we looked at, well, who actually got care and stayed in care? And it was very, very, very small. And, as a report came out from the national academies, many of you probably have seen it, solutions existed in the wild to help with the opioid epidemic, right? Medication for opioid use disorder. It's effective, but it wasn't being prescribed. And thus those who need it didn't get it. And as we're thinking even more about this, right, we know that it's part of an access problem, right? So people with OUD aren't getting care. It's a continuity problem. If they can find their way to care, they're falling out of care very quickly. People with mental illness were disproportionately prescribed opioids. And we knew that it was a workforce problem because there just weren't people to prescribe in half the US counties, right? The waivers. And it was a workload problem because, interestingly, even if you had a waiver, you're still practicing well under your caps. And so NIH was charged, and when I say charged, I mean given a lot of money to help solve this problem. And this was through the NIH HEAL initiative. In 2018, Congress gave NIH $500 million, and this was to go forward. So not just one-time deal. The money, it's more than $500 million now that NIH receives. This was an all-hands-on-deck activity. So a lot of times the way that NIH operates is each individual institute has its own priorities. And if you have ideas that sort of cross institutes, it's not seen as a benefit. It's more of a hot potato of does it really belong with us or does it belong with this other institute? HEAL cut through that and said, no, everybody needs to work together and figure this out. And so what could some near-term solutions be to the opioid epidemic? Well, collaborative care really came to mind. There's strong evidence across a number of services outcomes, but we know that it's not a panacea, right? We know that it improves access, continuity, quality, and value of care. It's associated with health disparities. Services at this time were reimbursable by CMS and a number of other commercial and public payers. And there was a promising trial out for opioid use disorder as well as alcohol use disorder. But the findings were very, very modest. And we also know that there have been some negative trials, right? So especially in the area of PTSD, it's really important to kind of get the formula right. And so as a program officer, I was thinking, well, what is the research agenda here? And so, NIMH was tapped to come up with a solution, come up and be part of the solution. And so, thought, well, why not put an RFA out, which is a funding announcement with set aside funds around collaborative care for people with opioid use disorder and co-occurring mental health conditions. As a program officer, I don't do research anymore. But we do compete for funds, right? And so although NIH had $500 million, you can imagine across the spectrum of research, there are a lot of good ideas. And so, they were looking for ideas. And so you are competing for funds to support a program of research. And so I and colleagues put together an RFA to test the collaborative care model for people with OUD and co-occurring mental health conditions. And you can see here kind of what we had in the RFA. We had some primary questions that we wanted answered. Obviously, we wanted clinical effectiveness, but also there was such a problem with access and continuity of care. We wanted to see how well we could sort of scale this model. And then we had some secondary questions. NIH really wanted to know, well, what do you treat first, the mental health or the opioid use disorder? And we wanted to know, how well did the existing financing mechanisms really create a winning business model for systems and primary care clinics looking to implement collaborative care. So we funded four large projects. The total set aside for this amount was $50 million. This map is from a couple years ago, but you can see kind of wide coverage across the United States, diverse populations, diverse readiness for implementation of collaborative care, and really kind of excited to be funding this work. So in addition to funding work, we fully recognize, especially in my division and branch, the importance of partnerships, right? So from NIMH, it's great to do research, but we don't want our research to be done in a vacuum. And at the federal level, it's being a program officer, or being a federal employee, it's pretty easy for us, well, in theory, it's pretty easy for us to reach across the federal aisle and develop partnerships with other organizations whose charge it is to actually deliver those services. And a couple of years ago, we had a partnership with HRSA. They were wanting to implement the collaborative care model in nurse-led health centers. And so we provided technical assistance and eventually supported a contract to the AIMS Center from the University of Washington that actually provided implementation support to those nurse-led health clinics. We're working right now with SAMHSA on their certified community behavioral health clinics, the CCBHC model. There are SAMHSA funds, I think about 500 of these across the United States. Each one is $1 million for 4 years, so it's a big taxpayer investment. CMS also supports demonstration of the model, which is sort of a different funding, and there's some CMS and SAMHSA are also working together. And so we're working with SAMHSA to really help develop a research agenda and kind of in sync with one of their funding announcements. We issued a notice of special interest that said, hey, we want research that partners with CCBHCs so that, our research agenda and their research agenda and their practice agenda really is in sync, so we can, help improve the provision of services for people that the CCBHCs manage. And also right here on the bottom right, one of my colleagues, Michael Schoenbaum, actually really provided a lot of technical assistance to CMS as they developed the billing codes for the collaborative care model. Recognizing that we're kind of limited at the federal level, we really want our researchers to be partnering. with organizations that have some decision authority. So we have 2 notices of special interest out, and here kind of referencing the U.S. Preventive Services Task Force. As you know or may know, A and B level recommendations that come out of the task force are tied to the Affordable Care Act, such that those recommended services must be offered at no cost sharing in commercial plans. Now, some of this is tied up in litigation currently, but hopefully that'll get resolved. We funded a project to Doug Zatzik and Eileen Bulger. This is a collaborative care model that enhances collaborative care in acute care trauma settings. And what's so appealing about this is they have a partnership with the American College of Surgeons Committee on Trauma. And if you don't know, the American College of Surgeons Committee on Trauma, their recommendations actually have some teeth to them. You know, they have financial incentives associated with following and not following, and they have a whole verification process that takes place. And so this is, you know, kind of a really exciting way of how to think through partnerships. A project to David Smelson and colleagues, they partnered with third-party payers as they develop their application and the design of the study. They have an intervention called Mission that has been very effective in, I don't know, like 15 trials or more. However, it's completely unaffordable. So they work with third-party payers to design adaptations of Mission to test that arguably is probably going to be less effective than Mission in full, but it's also going to be more affordable. And so third-party payers are saying, well, if we meet these thresholds, we're willing to pay. And finally, you know, we have a project to Kimberly Hogue and Mary Acri. This is a P50 Alacrity Center, and they're working with state policymakers and trying to figure out like how they're using information and how to make sure that like they're making good information, making good decisions, knowing full well that the research agenda and our timeline doesn't necessarily sync up with, you know, the policymaker agenda. So we recognize that researchers need to start somewhere. And I can just put a plug in to say that NIMH supports training across career stages for pre-docs, postdocs, early career faculty, and opportunities for mid-career and senior faculty. We have 3 primary funding pathways. These are the individual awards for research and training, such as NERSA, F, and dissertation research awards. Institutional training and research education opportunities through like T32s and R25s. And administrative supplements to investigator-funded research project grants. So this is not my area of expertise, but definitely see our training website, and there's a program officer, and I'll mention her name soon, is happy to assist if you know if you're interested in a training project. As you're thinking about research ideas, you probably go to PubMed, which is the most logical place to see kind of what's been published recently about the key findings. You might look at other reports that have been published. But just know that we want to make sure that you know your idea kind of aligns with our priorities. And so we have a strategic plan for research. My branch supports research that primarily aligns to Goal 4. There's a new strategic framework for addressing youth mental health disparities. Check out NIH Reporter. So this includes projects that are currently funded and that may not have already published findings. So you may not know. And it's important because if you come up with a project idea and we just funded something, maybe we'll want to fund it again because it'll show replication, but perhaps we'd say, well, we're just funding this other thing. And so we're not going to fund your project. So this is a good way to kind of get ahead of that game. And then also there's a link to, you know, funding priorities and announcements. Definitely contact a program officer when you have an idea. You know, here is my branch. So me, Susan Azarin, Mary Acri, Jennifer Humensky, Victor Lucian is a brand new PO, just started Monday. And then our training program officers, Belinda Sims and Maggie Sweeney. Definitely reach out to us when you have an idea. Send us a concept paper. That's the first thing we're going to ask for. You know, it's just to, you know, have a concept paper, you know, 1 pager, 1 to 2 pagers, specific aims, background, any references. And that's really, really helpful as we think about for us to help you. And so coming full circle, right, the collaborative care model in the DoD, right? It was really exciting to see collaborative care recommended in 2016 for depression and again in 2022. To my knowledge, the VA DoD CPGs are the only guidelines in the US that actually evaluate collaborative care. And this is due because they actually ask about it in their key questions. So if you're developing guidelines and in your key questions, you're not saying something about collaborative care, When you go to do the evidence review, you're just not going to find it because you're not looking for it. So, it's great to see that. In 2017, they recommended a week 4 for collaborative care for PTSD. I'm not entirely sure what happened in 2023. It seems to be not evaluated again. But in 2017, the work that I had done, and we had published just after the evidence review was done, and really appreciate the guideline group giving a nod to the work, saying, hey, it's important, the findings were there, but we just couldn't officially include it, but we'll kind of unofficially mention it in the guidelines. And then something strange happened in March of this year. The Secretary of Defense, through, I'll get the acronym right here, the Suicide Prevention and Response Independent Review Committee, right? Secretary of Defense said, hey, we recognize collaborative care is important and there's evidence for it, citing our work, and we want it implemented again. So this was really gratifying to see. And just some concluding thoughts before wrapping up. So on the right, just some things to consider, because I wanted to at least answer the questions that Jeff and Maria had asked me to answer and to talk about. So mentorship, get it where you can get it. You may have official mentors, which is fantastic, but there may be other people that you might think of as unofficial that you have a relationship with. Listen to what they say, and not just about clinical work or your professional degree, but also about things maybe adjacent to your work, like management of people, like building systems and things that are really crucial to delivering good service, but that maybe aren't taught, formally as part of your education. It's important to be persistent. So there are grants that I really am so glad to see funded, and I know that the investigator reapplied, and it was really frustrating and trying to work and trying to get these projects funded, but you have to be persistent. It may take several times to get your work funded, but hopefully it will be. I'd say conviction and preparedness and priority alignment. So when you reach out to a program officer, come with a research idea that you really believe in. That's, again, in the form of a concept paper. It doesn't need to be more than that. But we as POs cannot be part of your study team. We can help align your research to our priorities. We'll advise on things like design and other things as it pertains to our priorities. We have, NIMH has a very big carrot, which is money. But there's a firewall between what we can tell you what to do and, so we can't be a part of your team. So you have to come to us and we can advise based on that idea. And, check out our priorities, because NIMH is just one of many funding organizations. And there are a lot of really good ideas that we just won't fund because they don't align to our priorities. So that's really important. And I'd say if, any of what I described piques your interest, I know the purpose was to talk about your careers as a researcher, but kind of like me, I kind of found myself in some unexpected situations that were like, this is really interesting. And I'm glad that those situations presented itself to you. Come join us as a program officer. We have many careers, there are many positions open throughout NIMH. There's a QR code and a link there. So take a look. And with that, thank you very much for your time.
We have about 5 minutes for questions. There's a mic in the back if anyone wants to be brave and be the first one.
Thank you. I'm again, I'm working on the delirium research and hi, thank you very much. So I'm working on delirium research, and my idea can look crazy because of the sometimes when I submit grant, reviewers' opinion totally split. Like one reviewer loves it and one reviewer hates it. Then usually that gets triaged easily. So that can frustrate me, and I don't know if the true innovation can be agreed upon at the early stage, and how can PO and your division or NIH can help with that? Do you have any thought?
Great question. So the role of a PO is sort of at the front end of when you submit. We have nothing to do with the review. We just sort of listen in, and then in the back end, help shore up your application. Should it be close to funding? Responding to reviewers is, they're people. They have feelings, and so sometimes reviewers want to know that you've taken and listened to their feedback. There are times as a PO where I look at a summary statement and it's like, oh, what is with this one reviewer? How did they miss how do they miss this? And it, of course, drives the score up, so in the wrong direction. The way to get around that, and it's not, it's like a solution that's, might lead to funding, right, is just making sure that you've talked with a program officer at the front end and at the back end, right, really trying to convey how much your project aligns to the priorities, because it's not like we don't fund things that are outside those priorities. They're deliberately vague, but the more your project can align to what the funding priorities are, the more leverage we as a PO have to kind of nudge an application kind of up or down. So there's certain applications that score well, but they're just not really aligned quite well, or they kind of miss the mark. And so we nudge them to not fund. And there are other applications that may score marginally, but that we really like because it hits on an important area, and maybe the reviewer just kind of didn't quite get it. And so we'll be able to nudge those in a more favorable direction. So that's probably the best. Yeah.
As you think back over these career trajectories, are there certain things that now looking back you say, well, that's what really caught my eye. That's what sort of really tugged at my heartstrings and made me go in this direction when that opportunity was there?
Yeah, I mean, the light bulb moment really was around this idea of population health. And it was, I mean, when I first got started, again, it was as a clinician, and my circles were around like kind of what to do with the patient in front of you. And then, listening, and thankfully not on, listening as an outsider, not on the other end of hearing folks from hearing, Wayne Caton, Jürgen Nitzer, Doug Zasek, like talk about collaborative care and making the case to, a very well-known researcher, psychologist. And it was just like, oh, I got it. Like, I got why we need to be thinking in a different way. And, to think that like, it's just kind of naively, like, this is only the person there in front of me that I should be caring about. It's like, it's true, except for the fact that how many people are like at my door, because there's a, waiting list, and how many people are not raising their hand and saying, hey, I need some help. And I think that was really kind of the light bulb moment, because it wasn't part of, my training, or really what I thought I want to be doing.
So I just want to tell you how gratified I am to see you all here, and to thank Michael for coming, and for Jeff and Maria for making this possible. And I won't be able to stay for Priya's talk, but and all you all folks, I hope you learn a lot in your breakouts. Michael's going to stay for a couple days. So, and what he said about program officers is they're on your side. They're trying to help you shape your research to fit our priorities so we can fund you. So please take advantage of having him here. Please give us feedback on how this session goes. This is an experiment for this meeting, and I really wanted to try to bring some big R research to the meeting. But I started out in little r and managed my way as an administrator, actually, like Michael has shifted paths. And so talk to us and just learn how there's a lot of different ways to do research. I see a lot of folks here. All right. Thank you so much for being here.
Thanks, Maryland.
Wonderful. Thank you, Dr. Freed. Now we're going to shift directions to kind of the other end of the spectrum of being a clinician who has research integrated into their career with Dr. Gopalan. She's an associate professor of psychiatry, assistant professor of obstetrics and gynecology and reproductive sciences, and chief of psychiatry for the Magi Women's Hospital, and medical director for the Psychiatry Consult Liaison Service across 9 hospitals in the UPMC system. She's been active in programmatic development around CL psychiatry, perinatal mental health, and in subspecialty integrated care. Her interests include CL psychiatry, healthcare administration, resident education, perinatal mental health, including addiction, dual diagnosis, and trauma-related disorders. Thank you.
And get this to work. Yeah. Escape from now. There we go. This is kind of. Ooh. Okay. All right. So thank you all for being here, and thank you so much for inviting me to be here. I kind of titled this with nothing and then actually gave this the title to my talk, because when I first got the email from Dr. Prom, I said, why in the world am I being invited to do a research talk? Because I, full disclosure, do not identify as a researcher in any way, shape, or form, not even kind of the little r researcher. So I actually emailed, I think, Dr. Prom and said, are you sure you got the right person? And they assured me, Dr. Bradley and Dr. Prom assured me that in fact, a lot of the people in the audience may not be interested in doing the kind of research that is funded by the NIH and that kind of thing. So it occurred to me that it might be helpful for me and maybe for other people who are leading some of the breakout groups to actually get a sense of who's in the audience. So you put your hand up if you're a trainee. Okay. All right. Can you put your hand up if you are in some kind of research pathway, either in your training program or in your faculty program? Some sort of promotional path. Okay, so that is actually a smaller percentage of the room. So I can feel confident in saying that what I am going to be talking about might be relevant to a lot of you in the room. So I always start with actually just putting this up because I think this will resonate with a lot of CL Psych folks. Like, we sit between hospitals. So I feel like my heart is at Western Psych at UPMC, but I also feel very strongly connected to the hospital where I actually do consults, which is Magi Women's Hospital. And I'm very grateful to the opportunities that I've had over the years. So it's kind of interesting because the slides don't go forward here. they go forward up here. So no disclosures for me because I am not a funded researcher. But I will talk a little bit about how to get academic productivity without funding, which is actually kind of fun and interesting to think about. And these are my objectives for today. So I want to talk a little bit about just opportunities in actually creating academic projects and dissemination. I'm going to talk a little bit about challenges with executing academic projects. And I use that term kind of loosely because I do a lot of educational work and then I do a lot of administrative work as well. So I think this sort of encapsulates a lot of the work that I do. And, we'll give a little bit of my own perspective in terms of tips and ways to enhance your academic productivity, given that a good portion of the room is not going to be like looking for NIH grants and writing a lot of research papers. So I'm going to do this by talking a little bit about my own career path and personal story. And I'm really going to sort of break this into 2 sections, like how to think and publish and conceptualize projects as a clinician educator, and then also thinking about how to do this as an academic administrator. And because I do a lot of teaching and education, I'm going to try not to talk at you for the next 40 minutes or so. I am going to sort of elicit some participation as well, because I hate talking at people. So just to give a little bit of a perspective of where I started, I joined our institution CL service in 2011 after training. I was appointed as the medical director in January of 2014, and then shortly after was appointed as a co-director for our residency's ACE track, which is an academic administrator clinician educator track at Pittsburgh. And this is, kind of it's a mouthful. I'm going to refer to it as the ACE track because it's just easier to do that, but it does encapsulate both the academic administrator part. It's not going forward. The academic administrator part and the clinician educator part. We kind of talk about both aspects, and I'm going to go into a little bit of that and why that is later. And I didn't realize at the time as an early career attending that these are actually kind of divergent paths, right? Like doing educational leadership has its own set of ideas and things that you kind of have to think about. And then administrative leadership really goes into a whole different set of things that you have to think about in terms of outcomes and conceptualizing projects. But as a very kind of naive early career psychiatrist, I was like, okay, sure, I'll do this. Let's figure out how to make it all work together. And thankfully, I'm glad that I did, because it's been a lot of fun. But it is hard, right? It is hard if you are a clinician educator. It is hard if you're a medical director to actually be able to be academically productive, right? To write papers, to do projects in a way that that journal reviewers actually think about and care about, because oftentimes we have some limits. So if you're an educator, and how many of you identify as a clinician educator in this audience? Just out of curiosity. Okay, so a lot of you. The things that we do are kind of low rigor in the very traditional sense, right? Like, they're not multi-site studies. These are not things that you're going to execute across multiple training programs. You're really looking at your own in a lot of instances. That's a huge challenge, right? So the things that we're publishing are, well, look at this cool case that really taught my trainees a lot, right? Or it's, let's look at this curriculum that I'm doing, and let's figure out how to disseminate this, because it's really cool. Like, the work that we do is really cool. I think quality improvement has its own set of challenges, and I saw we have some quality improvement experts who are like talking later on today in the breakout groups. The study design often is not as like rigorous as something that you would submit to the NIH, right? Like, it's often, hey, we're doing this program. We think it's really cool. Let's look at outcomes and see if it's actually helpful in terms of outcomes. Or, if you're fortunate, and you have an infrastructure to set things up more prospectively, let's actually design something for this clinic that I'm creating, or this program that can look at outcomes. But oftentimes, even with that, you're in this sort of lower rigor realm, right? Like, it's a single institution. Again, you're not necessarily randomizing patients, because that obviously flies in the face of clinical care, right? So you have these challenges. And then how many people in this room have protected time to teach, just out of curiosity? Okay, like 3 hands. Okay. How many people have protected time to do administrative work? And I'm talking like not catching up on notes, but like time to like think about programmatic development. Okay, I see maybe 6 or 7, a few more. So that's good. But time becomes a real challenge in these cases, right? Because you're doing the work and then you're going home, right? And ideally, you're not like doing a lot more work, although I'm sure that's also a challenge for many people in this room, because they know how healthcare works. So early on, I was actually really fortunate, because there are a lot of training opportunities out there that I think we just don't think about, and we just don't sort of think to look at. So there are organizations for quality improvement. We'll talk about that in a couple of minutes. But the AAMC has a lot of trainings that are really, really easy and accessible. This one is pretty affordable. I have no affiliation with AAMC or any of these other institutions. I just did this training and I thought it was really excellent. So I put it up there, and I did this as an early career, so that as an early career individual, so that I could actually feel not like an imposter as I was training residents to think in this way. So this is one that I really recommend. And I am really fortunate, because the University of Pittsburgh, and my department in particular, was pretty forward thinking when our chair took over, when I was a resident, 17 years ago or whatever it was. He actually said, you know what, we have researchers who get promoted at our institution, but we do not get clinician educators to really go through this like promotions pathway. So we need to change that. So I was actually a pilot individual for a clinician educator faculty development program at our institution in our department. This is actually specific to our department. And it has evolved over time to actually, it's now set up in a way where everyone gets a clinical navigator the first year, and then your second year, you're actually eligible to join this program. And because I see that a lot of you are in positions of power and in places where you can actually implement some programmatic change, I highly recommend this pathway, because it does actually support early career clinician educators in developing some of the skills that you need to actually be successful in what you're looking at. So this is specific to clinician educators. UPMC is a large healthcare system. So a little bit after this was started from our department, UPMC as a whole actually put forth a physician leadership essentials course. And again, many of you are in large kind of systems, large consolidated health systems. And what this did is it actually taught me how to be a better medical director. So it helped me to sort of make the connections with administrative people, with our data analytics groups, with our quality improvement folks, people who actually maybe have some time set aside to actually think about some of these things. So these were all very, very helpful, right, in terms of career development, but also things that are not exclusive to the system that I work in. Like, these are all things that, in theory, you could implement wherever you are. So I'm going to break this down a little bit. sorry, break this down a little bit just to talk about each of these different areas. And again, we seem to have a split here in this audience, so I think we can hopefully tailor this to this group. So I've alluded to the ACE track here. I wanted to spend a minute or two talking about what that is, just because I'm going to reference it a couple of times as we move forward. I actually stole these slides from someone. I don't know who. I'm sorry. Normally I put like a slide credit when I when I steal slides, but our chief residents like hand it over year to year. And I know somebody created this, but I don't remember who. So our residencies, ACE track, really was designed as the parallel to a research pathway. We have a very formalized research training program that's been around for decades. And this was developed really for all of the other people who are not looking to like be on the T32K course. And we kept it intentionally broad because we knew that not everyone was going to be a program director, that there were many people who were going to be doing, health services delivery, medical, doing more administrative work, that sort of thing. So we kept it intentionally broad. But the core components is during your PGY 3 and 4 year, you attend meetings that cover a variety of topics that could be something like adult learning principles, or it could be hospital finance and budgets. We do a lot of early career panels to support people who are, kind of going through what the residents will be going through in a couple of years. We require a scholarly project. So this is why I ended up like scrambling to get some early education, because I was like, well, if I'm going to have to mentor people in scholarly projects, I better know what I'm doing. And then we sort of build in a lot of mentorship into the program. And we really are hoping to develop skills and leadership for our residents who come through. We have clear objectives for the track. We actually have a written curriculum for the track. And this is sort of the evolution of our track. I don't have it more updated again, because I stole the slides from someone else, but it's been around since 2008. It's been going for a while. And in 2016, we did a survey of people who graduated from the track, and we had some pretty good results from that in terms of what people ended up doing. So we were pretty comfortable that we were meeting the goals and objectives of the track itself. And then we kind of did it backwards, and we sort of solidified and codified that into a written curriculum. And then we actually have resurveyed people this year, although we have not yet published that. And the reason I give that background is to really encourage you all to think about outcomes for the things that you are doing already. So in this particular instance, I'm talking about educational products. So I'm going to sort of ask this of you all: what is an educational product? Like, what defines it, or what are examples of it? Like, what is it? Okay, so maybe something around educating nurses around alcohol, like managing alcohol withdrawal symptoms, and really kind of putting some structure to that. Okay, yeah. Okay. Okay, perfect. So something that really gives structure to what you're doing, that has clearly delineated components to it that could sort of be taken and picked up and maybe replicated. Okay. Yeah. Okay, so really thinking concretely about outcomes. Is this an effective curriculum? And I would make the argument that all of the educators in this room really should be thinking about this, right? Because why are you doing the teaching if you're not worried about whether or not what you're actually teaching is being absorbed by the person that you're teaching to, right? Otherwise, we're just, I don't know, talking at people again, right? Any other thoughts or ideas on this? Okay, so I went to Google. That's what I did. I went to Google and I said, what is the definition of an educational product? And this is pretty vague. I kind of pulled together a couple of different sentences. And it said materials designed to educate others with a formal structure and teaching as the intent. This was not an exact quote, but sort of pulling together a couple of different sources, which I didn't really love as a definition, but I think you all sort of defined it better. I like what you all said first, better than what I found online. I put up some examples of what could be an educational product. I really pulled this based on our own promotions pathway at Pitt, but I'm sure that each of your institutions has something similar if you have a clinician educator track at your institution from a promotion standpoint. And I kind of divided this into two parts. I don't know if these are not hard lines by any means, but, I have on the left side of this dissemination of initiatives that you've done. So you've done this really, really cool thing. You want to get the word out that you did this cool thing that was really effective and really innovative. So there are different ways to do that. It could be a manuscript publication, obviously, right? Like if you want to submit to academic psychiatry or their journals for the GME, there are a bunch of different places where you can publish these things. But you can also publish to, I think there are organizations that do model curricula where you can put that together as a document and submit it as a model curricula for them to publish on their website or what have you. MedEd Portal has a mechanism for submitted curricula. So I wanted to kind of turn people's attention towards there. And of course, you can always disseminate. It's not really a written publication, but it's certainly a product if you want to do posters or other kind of national dissemination work in this area. And then I kind of divided products into where it's not necessarily a published product, but it could be, but where teaching itself is a goal of the thing that you're creating. So maybe you've done the curriculum, or maybe you just want to tell people something, right? I think we see this oftentimes in position papers and things like that. I see this all the time, and this is not the way you guys should be doing care. So let me write a paper to educate you all. And I think that's the other way to sort of think about educational dissemination as well, right? Let's publish some teaching guides. Let me talk to the NNCI people or the NCRP individuals, which are national curricula in either neuroscience or reproductive psychiatry, and see if there are things that I can publish there. There are a lot of opportunities, I think, that we don't really think about in terms of dissemination, and certainly in terms of creation of structure that really are very conducive to the things that you're probably doing day to day anyway. So we did that for the ACE track. We did a follow-up paper at 7 years. We're working on another one, like I said, and it's been kind of an interesting thing, but what it has helped us to do is every time we look at what we're doing critically and looking at the outcomes, like some of you have mentioned, it makes our product actually better, right? So whatever it is that we are teaching on, whatever, we're involved in, it ends up improving upon it because it is helping us to sort of think critically about what we're doing. And I'm not a medical education researcher, so I don't want to discount that entire kind of area of education, but I do think it's important for us to sort of channel that kind of side of us if we can. So why do it? I sort of told you the what before I told you the why. Why create an educational project? I'm going to turn this back to you all. Why not just go to work and teach and go home? Probably alluded to some of it. Promotion is one of them. I've sort of mentioned that a couple of times. A lot of places require you to have those types of products. Absolutely. Thanks, the hand up. Yeah. Yeah, absolutely. So something that can be standardized and maybe replicated and can be scaled. And I think somebody else alluded to this, if you leave, that thing goes away, right? If you don't have some structure to what you're doing, if it's not in some sort of tangible form. I saw a hand over here somewhere. No. Okay. Yeah. Succession planning. Absolutely. Yeah, absolutely. Mm-hmm. Yes. Yeah, absolutely. Anything you have kind of written with clear objectives, it's going to make it easier for you in the long run. Anything else that people can think of? Yeah, absolutely. Tell me more. Say more about that. Mm-hmm. Yes, absolutely. So when you really think about what you're doing objectively, it becomes a way to educate others. So I happen to know Dr. Fonseca's work. So, using that to really amplify the voice of something that you're very passionate about can be really, really important. And, if you don't really put some structure to it, you just do it, and that's fine. And that's okay on a micro level, but it does not actually serve you very well on a macro level. So I'm going to get off that particular soapbox. So, all right. So we kind of talked about all of these already, but I think, some of the pieces that we maybe didn't talk about as much is it also permits growth, right? So we did the first follow-up paper for the ACE track, and then we said, you know what, we need to sort of keep looking at this. We can't just do it as a one and done and just sort of stop there. So we do another one, we do a follow-up one to make sure that we're still meeting the objectives of what we're actually trying to achieve. What are the challenges? Sorry, I'm not going to let up on you all. What are the challenges to avoiding redundancy? Okay. All right. Yeah. There we go. Right. Absolutely. Yeah. Time is a huge barrier for a lot of people. And absolutely, there are a lot of institutions, myself included, that definitely place a higher value on a peer reviewed publication than a published curriculum. Yeah. All right. Let's go back to the side. Yeah. Keeping them. Yes. Yeah. Yes. Yeah. Right. So there's kind of a scale issue as well, right? In certain instances, and then you mentioned the keeping things up to date. You had your hand up. Yeah. Yeah. So the scale kind of issue as well. Yeah. Yes. Mm-hmm. Absolutely. There are entire master's programs on medical education, right? Like in doing med ed research. And a lot of times we're just kind of doing this as we go and kind of learning it as we go, right? Yeah. Anything else that people can think of? I thought I saw other hands. Yeah. Mm-hmm. Yeah. Yeah, absolutely. So I think that sort of speaks to the lack of training often that we are faced with. Medical school education especially doesn't always incorporate med ed research as part of their curriculums, but pairing with people who have that expertise, you can certainly think about that. We'll talk about that in a second. So I have my tips for my top three. It's like my top three for developing an educational product. This is not going to be like rocket science for anyone in this room. And my biggest one is to really consider what you're working on, because I think a lot of times we sell ourselves short, and we're doing these really cool things at the bedside, and we just don't think of it as being innovative or novel enough to actually disseminate or to like look at critically. So this can be as simple as a lecture that you're giving for a CL fellowship, or it could be a series of lectures that you're going to give to the nursing staff about alcohol withdrawal because you are just fed up with the way it's being done at your institution, right? These are things that I think in CL especially, we do all the time and we just don't think about it. And if you're going to do something, you may as well put some structure to it. So this is something that I talk about and say to our residents all the time. So if you're doing a curriculum that you think might be interesting, do a pre and a post survey on it. Do some feedback. It's not a high bar necessarily to generate some outcomes for educational work in particular. So this is an example of one that these are a couple of examples of things that we did. This is from a neuroscience curriculum that we published. We thought it was interesting because it is a longitudinal curriculum, but this is one that I thought was particularly interesting because the clinician educator faculty development program is pretty novel. I was, fortunate to actually have engaged in it as a participant, but the people who actually came up with the program published it. It's out there, and it's cool. Like it's fun stuff. And that sort of brings me to my tip number 2, which is really to be very systematic in the way that you think about everything that you do. So I would do nothing from an educational standpoint without thinking about a pre-post survey and at least feedback. You may not do anything with it, right? Like you might look at it and say, okay, well, this is cool. We met the targets that we wanted to meet. You may never publish it, but wouldn't it be nice to kind of have that option if you wanted to ever move anything forward? So I would say short of maybe single lectures maybe a little bit harder, but if you're doing anything that's like 2 or 3 or 4 parts, you should definitely put some structure to it and, catalog it. You don't have to publish everything you work on, but you should have the option to do it if you want to. And if it's not, high rigor enough to publish in a manuscript, you can still present it. There are a lot of academic conferences out there. You could definitely still present it in some forum. Okay. So just some examples of this. This was, videos that we had made years ago. These are sort of old now, but these are videos we had made a long time ago. Again, pre and post surveys, I think utilization, I think that's what we had done there. This is something that was a resident ACE project actually many years ago. Dr. Spada is now an attending, has been for several years. So, but she published on a self-assessment of teaching skills that she did, and then a workshop that sort of went along with that. And my tip number 3 is really to follow your passions. Don't do this for things that you're feeling lukewarm about, because you're never gonna really get any enjoyment out of it. So that was sort of my biggest advice to people who kind of come through our ACE track, is don't do a project unless you're really excited about what you're doing work on. And I use this as an example because, I think a lot of you in this room know that I do perinatal psychiatry. It's something that's really fun and interesting. And of course, as many of you I'm sure have done, we said the OB residents need more teaching on mental health. Like, this is just not something that they're getting enough of. So we did this, and it was actually an ACE track project, a resident project that I mentored, and it was cool because it's our psych residents teaching the OB residents. So it was like very well received by the OB residents, and we ended up being able to publish on it. And again, this was just based on pre and post survey data. This is not like high stakes rigor, right? Switching gears a little bit and also watching the clock, administrative scholarship. How many of you are medical directors in this room? Okay, so a handful. How many of you are like some kind of quality improvement or patient safety specialist of some sort? Okay, a few more. So this is the world that you all live in, right? Like, this is the world that you have to think about. My job is interesting. I love it. I really do, actually. It's an interesting system to work in. But I work in a very large consolidated health system, and this is the trend in the United States, right? So this is, that graph up top is 2000. The red is like hospital systems that have been consolidated into like a multi-hospital kind of network of some sort. And then down at the bottom is 2017. And I'm going to guess that this has increased even more over time. This is the trend in healthcare, which poses some interesting challenges. These are all the H's here are UPMC hospitals. UPMC has over 40. And that includes sites internationally, but also includes sites in Pennsylvania, New York, and Western Maryland. So anything that I do, I have to think in terms of scale and sustainability, which I think is really, really interesting, and also provides a lot of opportunities to think about quality improvement and putting structure to what we do. So we have multiple sites that are in person. I'm not going to go into the details of this because it's relevant only because it's a lot. And then we have several telepsychiatry sites as well, and more sort of on the horizon. I keep sort of pushing back, and then people keep coming back and being like, no. But just to give you a sense of this, this is where Pittsburgh is, here in Western PA, right at the border of 3 states. These 4 stars here are actually where we do telepsychiatry currently. So anything that I do, I have to think about not just for our academic site where we have trainees and it's like this really rigorous kind of hub, but also to like, well, will this work in these other systems, hospitals as well? And what a cool opportunity that is, right? Like to say like, this works here, but can we actually make it the same or standardized in some way across different places? So once again, thinking about outcomes. And actually, before I move forward, what sort of things have you all investigated at your own place in terms of quality improvement or administrative workflow, or like, I'm seeing patients today and this thing is bad. Like, this should not happen the way it's happening. I want to make it better. Like, how many of you have done projects like that and would be willing to share what you did? Okay, a handful. People are laughing at me. That's maybe not a great sign, but okay. You had your hand up, I think. Mm-hmm. Yeah. Yeah. Oh, amazing. Yeah. 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 And you said you have some like pre and post kind of data for it. Did you publish it? All right. Good. Good. Hmm. Perfect. Yeah. Good. Yeah. And it's the stuff that you just do in your day-to-day like work, right? Like, sign out is a core part of what we do in medicine, right? Awesome. Others, I think you had your hand up. Yeah. Mm-hmm. Yeah. Yeah. It's yeah. Perfect. So it's, again, things that you think are really important from a clinical care delivery standpoint that you're able to kind of put some structure to. Yeah. Anybody else? Anyone else? Yeah. Jay. Mm-hmm. Mm-hmm. Yeah. 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 And that's challenging, right? Like that's another thing I think that is coming up over and over again is this idea of time and how do you sort of get that going? Jay, you had your hand up. Nice. Right. Yeah. Absolutely. These are all things that have direct implications on patient care, right? Great. Yeah. Mm-hmm. That's great. So everyone's like doing work that is meaningful, impactful, has data in it. And if it doesn't have data already baked in, you have like an ability to put some structure and data into this, right? Really, really important to think about. Thankfully, for those of you who are not familiar with sort of quality improvement frameworks, there's a lot out there on this. You'll hear more about it, I think, in some of your breakout rooms, and you all have really great ideas to sort of discuss in the breakouts later today, which is really cool. But I just want you to sort of point you in the direction of there are published standards for quality improvement. There are a lot of materials available online that you can look for. And there's a lot of guidance out there in terms of how to write up a quality improvement product for publication, because it's a little bit trickier because of all of the things that we talked about before in terms of, not being multiple sites and oftentimes lower numbers and that sort of thing. So I just want to point you in the direction of just thinking about how to publish, thinking about the why of what you started and what you did. And really, if you're not putting some structure to each of these steps, to really think about it, ideally ahead of time, like before you start diving into doing the work itself, to really putting some structure to it before, because I have learned from my mistakes on that one. There's a website it's here. I should have done it as a QR code. I'm sorry. But my slides are on the app. But there's a website that has a list. This particular link will take you to a list of journals that are friendly to quality improvement publications, because that's not always the case. And I will tell you, it is really, really hard to submit to a journal where all the reviewers are researchers when you have not really actually structured your project as a research project. I just wanted to put up a couple of things on here, though, as of things that I've done and I'm proud of, or that some of the people that I've worked with have done that I think are interesting and relevant to the group. So, we do inpatient CL consults to rural OB units. So we did a publication on that. The bottom left is something that it was one of those like, oh, I'm like really annoyed by this. There's no literature on benzodiazepine withdrawal in perinatal patients, like nothing, really, very little. So I was like, okay, well, I'm kind of annoyed. So I'm going to look at what we're doing and make sure that we're doing doing things the right way. This is just stuff that's just interesting to me. The ones on the right are ones that, at the time they were trainees, none of them are trainees anymore. Did that were just interesting, right? Like, let's look at trauma in the inpatient units. Let's look at what happens when a first episode psychosis person comes on CL. These are not like rocket sciencey kinds of things. These are things that I come across just in my day-to-day care, which I think is kind of fun. And really what these examples have in common, I was going to like ask you all this, but I don't think I have time to actually do that again. And these examples are all things that I'm excited about. They're all things that I see day to day. They're things that are enjoyable to me. So if I have to sit down and actually do work on it, I can actually sort of feel like I'm not working, which is kind of fun. Role of funding, I'm not a funded researcher. I have like applied every once in a while to really small sorts of things for like lunch and learns, like can we pay for food for, for this group or whatever, nothing major. But I will say, I wish I had thought about this earlier in my career. I am now, 12 years out from training. But there are a lot of foundation grants and smaller grants, at least in, I would guess like medium-sized cities and above. I don't know if, I don't know. I can't speak to anything smaller than that. That you could probably use for, curriculum materials, for like if you're doing an educational project of some sort to feed people to come and attend, to kind of incentivize people to attend. There are even foundation grants where you can do like patient incentives if you are doing a more formalized research project. And I wish I had sort of thought about this earlier, so I wanted to kind of say that here. It is really hard, at least in Pittsburgh, it's really hard to actually get time for physician time in these grants. I think that's a big barrier and a big limitation of these. But if that's not as big of an issue, if you have some time incorporated in for administrative work already, and a handful of you said you did, maybe that's less of an issue. Maybe instead what you need to do is like get the funding for the project itself and then go to your boss and say, I got this funding, but I actually now need some time to do it. Would you be willing to support that? And you're absolutely allowed to do that. And in some ways it's mutually beneficial, right? Sometimes, depending on your institute's culture. And I alluded to this, but I wanted to make this clear. I stole this from one of my colleagues. He and I teach a healthcare administration class to the psychiatry residents together. And he always puts this slide up and the residents don't like it. They don't like it. For obvious reasons. But oftentimes for those of us who are not in funded kind of research pathways where we can buy out our own time, this is kind of how it goes, right? You find something that you're really interested in and passionate about. And the blue here is like your clinical work. And then, this is the stuff that you're doing on nights and weekends, right? Like this is project development. This is, coming up with writing PowerPoints or whatever. And then over time, and especially as you start to disseminate it at places like this and in other places, people start to recognize that what you're doing is impactful and meaningful. And especially if you have outcomes to show for it, someone will say, maybe I should actually pay for some of your time to do this, right? And that's kind of how, again, I'm sure this is institution specific, so I'm not going to pretend that every place is as good about this as mine happens to be. But, over time, someone might pay for 10% of your time to do this, this initiative, or they might say, hey, you've done all this really great work. You've disseminated it. We can see that you do it well. I'm going to give you a leadership title, and then that will have time incorporated or something along those lines. And at some point you may end up being, more of a 50-50 split or more, depending on what you're doing. That's certainly how my career has progressed over time. I'm sure others in the room probably have had similar projections because I see nodding in the room, so that's always good. And my tips for this are very, very similar to what I said for educational products and projects, and that really is to really think about what you're doing, because again, you all are doing amazing work. We've heard, I think the examples that were given were all about patient safety and improving care for patients and handoffs and that kind of thing. This is like fundamental medicine, right? Like these are things that we're doing day to day. So consider what you're working on. You may not think it's novel because you do it all the time, but I'm going to guess that other people will think that these are novel initiatives because not every place gets it right? Again, you want to put some structure and systems. I said educational here. What I meant was administrative endeavors. I'm going to add a couple of things to this, though, and that is to really seek out some additional training. So get training on quality improvement. I think it's really, really important. We don't do it. We don't think about it enough, but there is a lot out there. And I also put in like learn how to use Excel, because if you can manage your own data, sometimes it's easier than going to like a big data analytics group or going to, I see a lot of nods right now, or going to like the EMR IT division and say like, can you give me X, Y, and Z? If you have a way to just kind of do that yourself, and if you learn the ins and outs of Excel really well, sometimes you can just do it. Like, should you have to? No, I will say that, but sometimes that's just kind of the practicalities, especially for me, like working in a large healthcare system, sometimes even finding the right person to like pull data for me. Like, I don't even know how to do it half the time. So I just kind of figure out a way to do it myself. My tip number 3 is the same here. Share your passions, share the things that you're really interested in. But I'm going to add a little caveat to this. I only did this in the last 2 years. And I'm going to say this with sort of a, I don't know, sheepish look or whatever. And that is that if you are in a institution that's not tiny, so how many of you are like medium to large size institutions? Okay. So like most of the, maybe 3/4 of the room, maybe. Chances are there's a research faculty somewhere who you have never crossed paths with because you just don't work in the same circles, who maybe has the similar interests and passions to you. I'm going to give an example of this. Dr. Shivnagar is here. She and I do a lot of inpatient CL work. the person who has published like New England Journal of Medicine articles on delirium research, Dr. Timothy Gerard, is at our institution. I've been at my institution for 16 years. I met him for the first time this year. And now we're like working on a delirium interest group and all these like fun things that are coming out of it. But seek out the research faculty in your department. It may not be actually even in your department. I'm working right now with a researcher in internal medicine who's doing proactive screening and predictive modeling for perinatal depression. And again, if you don't seek out some of these people, you might not even know that they kind of exist. And then, QI specific, you might want to think about funding there too. And especially for those of you who are in research tracks, really important to do. So my sort of closing kind of suggestions on this also for scholarship and publishing is also to use this conference. I think conference deadlines are such natural deadlines for us. Many of us are very deadline driven, I think. And when you and I know there's a good number of trainees here. Once you lose that cycle of being a trainee and graduating, and you 4-year cycle of med school, 4-year cycle of residency, 1-year fellowship or whatever, it's hard to self-direct yourself towards doing things and seeing it to completion. And I think it's really important to use some of the natural deadlines that are built in. So at this conference, I get super inspired, and then I start to write down things like ideas of projects and things that we can do in the next 6 months so that I can think about April 1st as like my deadline for that. And sometimes the work gets done and sometimes it doesn't, but at least you kind of have that cadence, right, to the work that you're doing. And then if that sort of bleeds over, then at least, that's fine. At least I know that I have that I at least thought about it and tried, and I use the abstract deadlines to my advantage. And then of course I use the conference itself as the way to really get the work done, because if you're presenting on something, you want to make sure you get the work done before that. Consider poster to paper. I don't know if Dr. Lee's in the room, but I think he's the one that said 25% of posters at conferences tend to get published. Ultimately, I think it's a pretty low number, which is, I see some like raised eyebrows here. Yeah, I was pretty surprised by that too. I'm going to put in a plug. We are actually doing a symposium on this as well. But I think it's a really like underutilized. You've done 3/4 of the writing already in a poster half the time. If not the poster, certainly if you combine the poster with the abstract that you wrote on the poster, it's like halfway there. I'm an optimist. I'm very glass half full if you haven't noticed, but it's really easy, right? And then thinking about academic productivity, the first thing that people told me, my bosses told me, is know when to say no. And I actually don't agree with this. I actually don't really fully agree with this. I say know your bandwidth. And know that your bandwidth stretches and shrinks at different times of your life. And there are times when you can juggle 5 and 6 projects, and there are other times when you cannot. And that's okay. That is absolutely okay. So I'm actually not a big fan of that advice of like know when to say no, because I don't think it's actually true for everyone that you have to, as someone who never says no. just to put that out there too. I mentioned this already, but partner with researchers. Many studies really, and I think Dr. Fried sort of spoke to this as well, really would benefit from a clinical eye. And finding those partnerships, oftentimes they are very, very welcoming of having clinicians involved. Sometimes they will not buy out your time to do that. So make sure that when you're doing it, you're doing things that are really exciting to you. But it's really helpful. Use mentorship. I mentor a lot of residents. It has expanded my productivity. It is not why I do the mentoring. Please make it a two-way street. Don't use it to your advantage to exploit people. But this is kind of a fun way to like expand your bandwidth, right? Like to support people and get people excited about the things that you're excited about. Recycle liberally. Recycle. Poster to paper is a great example, but if you're doing a PGY2 lecture, for example, use it in a grand round somewhere. Like recycle your slides. Don't reinvent the wheel. You can reuse things that you've done here at a local or a regional sort of event or at a hospital-based thing. Do it liberally. Don't plagiarize. Follow your passions again. And this is sort of a summary of everything I've said so far, but I think we have maybe a minute left, or maybe not a minute left for questions, but people have questions.
We can maybe. We can probably take one or two questions.
Hi, Priya. How are you? What would you say to people who sort of set out on an endeavor, realized that it was a really good educational product along the way, don't have a pre-test, are definitely interested in the post-test?
Yeah.
I think that has felt like some of the barriers for publication and dissemination and things like that?
That's a great question. I think some of that depends on if it's a one-time endeavor or if it's something that's going to recur. If it's going to recur, then you have an opportunity to do a pre and a post in the future. If it's a one-time endeavor, a post survey is better than nothing.
Sure.
And I think it's still worth doing, understanding that you may have to sort of lower the bar of where you submit to, like you might have to do it as a letter to the editor, or you may have to do it, you know, in some other capacity that's maybe not as rigorous, but absolutely you should still do it. I don't think that should hold anyone back. I think we all find ourselves in that position too, for sure. There's another hand up, I think, over there. Yeah. Yes. Oh, that's a great question. I don't know that I have an easy answer to it. I think the shorter the better, but addressing usually it's like attitudes, knowledge, comfort. That's kind of the general sort of practice. I'm a fan, and this is going to sound ridiculous, but for the get done piece of it, sometimes paper actually works really well for that. Like if the residents are all getting together at didactics anyway, like stop in, hand them some sheets of paper, and then you can put them into like whatever, you know, electronic form that you want to, but they're all there. They're like a captured audience, right? Versus like they leave the room, they forget what you told them kind of deal. So I'm kind of a fan of that. Sometimes it's just more practical. That's what we did for the OBs when we did that curriculum. And then you like input it in later, or like give them time during their didactics to do it, like put up the QR code and kind of have them do it there if you have the opportunity to, or if it's a structure that's conducive to that. But you know, that's it's a challenge. It's a challenge for sure. Yeah.
And that is the perfect opportunity to let you guys know we're going to have a post survey about this colloquium. So one other way is reminding people that you will receive a survey. So keep an eye out for that. All right. So I want to thank both of our keynote speakers. Another round of applause. I really appreciate that you both covered, you know, exactly what we're all here for, is that we're clinicians. We want to improve care. We want to improve patient outcomes. And the best way, as we've learned, is to be able to make sure that we're doing it evidence-based, that we're gathering metrics, and that we're improving care in a way that we know has outcomes in the direction that we're looking for. So for now, we will have a break. And then I'm going to put this up so everyone can see what room they're going to. So everyone will have a break until about 1:50, and then please go straight to your breakout rooms, which again are listed here. Thank you so much.